Welcome back to the deep dive. We have got a stack of notes here that would make a first-year resident sweat. We're looking at standard texts, Katie Tripathi, Stolting, Miller's anesthesia, plus the specific obstetric anesthesia guidelines.
The heavy hitters.
Absolutely. And today, we aren't just exploring a topic. We are, stepping into a very specific high-pressure scenario. I want you to close your eyes for a second. Imagine you're sitting in that uncomfortable wooden chair. The air conditioning is humming, but you are sweating. Across from you is a long table. Behind it sits the external examiner, looking over their glasses at you. You are in the hot seat. This is the Gujarat University MD Anesthesiology Viva.
That is a visceral image. I think every listener just had a sympathetic surge.
And the examiner leans forward, taps the table, and says, "Doctor, let's talk about antihypertensives in obstetrics. Specifically, they want to drill you on the two absolute pillars of the field, Methyldopa and Labetalol."
The classics. And look, if you just recite the dose, you might scrape a pass. But that is not why we're here. The mission of this deep dive is to get you the distinction marks. We need to strip these drugs down to the chassis, the pharmacology, the precise mechanism of action, the anesthetic implications, and of course, the obstetric applications.
We're going to break this down so that when you're in that exam hall, the answers don't just come out as memorized facts, but as a structured, logical narrative.
That is the key. It is about understanding the physiology. I mean, if you understand how these drugs hijack the body systems, you can derive the side effects and the clinical uses without having to memorize a list. That is the secret to surviving a Viva and, frankly, writing a structured 20-mark theory answer.
So here's the game plan. We are splitting this into three distinct movements. Part A is the old guard, Methyldopa.
Right.
Part B is the modern workhorse, Labetalol. And Part C is the face-off the comparison and the specific traps examiners set to fail you.
Sounds like a plan. Let's start with Part A, Methyldopa.
It really feels like this drug has been around since the dawn of time. If the examiner opens with define Methyldopa, what is the precise textbook definition they are hunting for?
You want to be surgical here, you say. Methyldopa is an alpha-methyl analog of dopa. Dopa, of course, being the precursor to dopamine and norepinephrine in our body's natural catecholamine synthesis pathway.
It's interesting because historically, this was one of the first, rationally designed antihypertensives.
But it was a breakthrough. And that leads to the obvious question, why is it still on the syllabus? I mean, we have newer, faster drugs. We have calcium channel blockers. We have better beta blockers. Why are we studying a drug from the 1960s?
Is it just nostalgia? Or is it something more practical?
It's safety, specifically safety in pregnancy. Methyldopa is the benchmark. It is the reference point for safety in chronic hypertension during pregnancy. The examiners love this because it forces you to weigh fetal safety against maternal physiology.
So it's a high-yield topic for that reason.
Very high yield. You should expect this as a short note on a theory paper, or specifically as a Viva question regarding its mechanism and its unique side effects, like hemolysis.
Okay, let's get into that mechanism.
Yeah.
This is marked as very high yield in the notes. How does Methyldopa actually lower blood pressure? Because I think a lot of people get the where wrong.
They do. The crucial concept to lead with the headline is that Methyldopa is a prodrug.
So it's not active in the bottle.
Correct. It's inert in its initial form. It has to undergo metabolism to work. And this metabolic pathway is something you might be asked to draw or describe step by step. It's a bit of a Trojan horse.
Walk us through that journey. You swallow the tablet, then what?
Okay, trace the molecule. It's absorbed, enters the circulation, and here's the first hurdle. It crosses the blood-brain barrier. It enters the central nervous system.
Okay.
Once it's inside the adrenergic neurons in the brainstem, it gets picked up by the same enzymes that make our natural adrenaline.
It's hijacking the assembly line.
Exactly. It steps onto the conveyor belt. First, an enzyme called dopa decarboxylase converts methyldopa into alpha-methyl-dopamine.
Okay, step one complete. It creates a dopamine lookalike.
Right. Then the next enzyme in the line, dopamine beta hydroxylase, converts that into alpha-methyl-norepinephrine.
And that is the payload.
That is the active agent. This is the key. Alpha-methyl-norepinephrine acts as a selective central alpha-2 adrenergic agonist.
Central alpha-2. We need to be very specific there. It's not acting on the blood vessels directly to squeeze them.
No. And that is the most common mistake students make. It acts in the brainstem, specifically the vasomotor center. Think of the alpha-2 receptor as a brake pedal for the sympathetic nervous system. It's a presynaptic inhibitory receptor.
So telling the brain to calm down.
By stimulating these receptors, it inhibits the sympathetic outflow. It tells the brain, hey, we have enough pressure, tone it down.
So the net effect is a decrease in the efferent sympathetic signals going down the spinal cord to the heart and vasculature.
Precisely. It turns down the volume knob on the entire sympathetic nervous system. Because you have less sympathetic firing, the peripheral vessels relax and the blood pressure drops.
I remember reading in some of the older editions of Stolting about a false transmitter theory. Is that still a thing?
It is relevant historically, and an older examiner, someone who has been teaching for 30 or 40 years, might bring it up to test your depth of reading.
Okay.
The old theory was that this alpha-methyl-norepinephrine replaced normal norepinephrine in the storage vesicles at the nerve endings. So when the nerve fired, it released this false transmitter.
Like shooting a blank.
Sort of. The theory is that it was less potent at the alpha-1 receptor than real norepinephrine, so you got less vasoconstriction. But we now know that while it does form a false transmitter, that is not the main driver of hypotension.
Okay.
The primary antihypertensive effect is that central alpha-2 stimulation in the brainstem. If you block the central receptors, the drug stops working. So for the exam, if you have to pick one mechanism, it is central alpha-2 agonism.
Got it. Central alpha-2 agonist via the metabolite alpha-methyl-norepinephrine. Now let's look at the pharmacokinetics, because this connects directly to clinical use.
It does. Absorption is via an active amino acid transporter in the intestine, but it's notoriously variable. Less than a third of an oral dose gets absorbed. But here is the massive Viva trap regarding kinetics.
I see this highlighted in red, the onset.
The onset of action. Methyldopa takes 4 to 6 hours to see a peak effect.
4 to 6 hours. In an emergency room context, that is an eternity.
It is useless for an emergency, and that is the question they will ask. Doctor, you have a preeclamptic patient with a BP of 220/120. Do you give methyldopa? The answer is a resounding NO.
Because by the time it works, the patient could have had an intracranial hemorrhage.
Exactly. The delay exists because it takes time to enter the CNS, go through that enzymatic conversion we just discussed, the decarboxylation and the hydroxylation, and build up enough alpha-methyl-norepinephrine to stimulate the receptors. It's a slow burn.
But the flip side is the duration is long, right?
Yes, it lasts 12 to 24 hours. It's a marathon runner, not a sprinter. It's partly metabolized in the liver and excreted in the urine. This is why, for chronic management, it's great. You don't need to pop a pill every hour.
Let's talk about what it does to the cardiovascular system once it finally starts working, the pharmacodynamics.
So because it reduces that sympathetic outflow from the brain, it reduces total peripheral resistance, or TPR. That is the main lever it pulls to lower BP.
Right.
You will see a small reduction in cardiac output and heart rate, but it is mostly about relaxing the vessels via the central nervous system.
What about the kidneys? This is always a concern in hypertensive patients who might have prerenal issues.
This is a strong point for methyldopa and a reason it stays in the formulary. Renal blood flow is generally maintained. It doesn't shut down the kidneys. This is crucial for exam answers regarding patients with some renal compromise.
And the CNS effects. Since we are messing with brain chemistry,
Well, since it works by depressing the CNS, sedation is the most prominent side effect. It causes drowsiness. It is, essentially putting the brain in a lower gear.
which brings us to the clinical uses. We've hinted at this, but let's formalize it. Where do we use this?
The primary indication, the one that keeps it in the textbooks, is hypertension in pregnancy. Specifically, chronic hypertension or maintenance therapy in pregnancy-induced hypertension, or PIH.
Why is it the gold standard there?
Safety data. We have decades of data showing no teratogenicity. It doesn't hurt the developing fetus. Crucially, it preserves utero-placental blood flow. So for a pregnant woman who needs long-term BP control to keep the baby cooking safely, methyldopa is the standard of care.
But again, we can't stress this enough, not for emergencies.
Never for emergencies. It is for maintenance,
Yeah.
purely.
Now here is where it gets really interesting,
Yeah.
and where the examiners love to dig. Adverse effects. Because methyldopa has some weird ones.
Oh, yes. The side effect profile is classic exam material.
Sedation we mentioned.
Yes. Sedation, lethargy, sometimes even depression or mental fog. It can actually cause cognitive impairment, which can be tough for patients trying to function in daily life.
But there's a specific test associated with methyldopa that always comes up, the Coombs test.
The Coombs test question is very high yield. Here's the breakdown you need to master. A positive Coombs test occurs in up to 20% of patients. That's 1 in 5.
That seems incredibly high. Does that mean 20% of patients get anemia?
No, that is the trap. A positive Coombs test just means the antibodies are there, Actual hemolytic anemia occurs in a much smaller percentage, maybe 1 to 5%, but you need to know the mechanism.
How does the drug trigger this?
It's fascinating immunology. The drug induces autoantibodies against intrinsic red cell constituents, specifically the Rh blood group antigens. It sort of alters the immunogenicity of the native epitopes on the red blood cell, making the body attack its own cells. It's an autoimmune type of hemolysis.
So for the Viva, positive Coombs is common. Actual hemolysis is rare, but dangerous.
Correct. If they develop anemia, you have to stop the drug. Other side effects include hepatotoxicity. It can cause a hepatitis-like injury drug fever. Nasal stuffiness is very common due to vasodilation in the mucosa. And fluid retention, which is sometimes called pseudotolerance.
Okay, let's put on our scrubs. You're the anesthetist in the OT. You have a patient on Methyldopa coming in for a C-section or maybe non-obstetric surgery. What are the specific implications for you?
First, because of that CNS depression and sedation we talked about, your MEC requirement is reduced.
MD being minimum alveolar concentration.
Yeah.
So they need less anesthetic gas.
Exactly. Their brain is already partially sedated. If you run your standard gas flows, you might overdose them or cause profound hypotension. You need less volatile agent.
And speaking of hypotension,
Be prepared for intraoperative hypotension. Their sympathetic nervous system is blunted. When you induce anesthesia, or even when you change their position on the table, they don't have that snappy reflex to constrict vessels. Their BP can drop fast and hard. You need your vasopressors ready.
should we stop the drug before surgery?
Generally, no. Abrupt withdrawal can cause rebound hypertension, though it's less severe than clonidine withdrawal. Usually we continue it up to the morning of surgery, but we anticipate the hypotension.
And are there any drug interactions to flag?
Tricyclic antidepressants, or TCAs. It's a bit niche, but TCAs can inhibit the transport of methyldopa into the neurons, essentially stopping it from working. It reverses the antihypertensive action.
That wraps up Methyldopa, the old reliable prodrug. Now let's shift gears to the modern powerhouse. Part B, Labetalol.
Labetalol is a completely different beast. If methyldopa is a sniper rifle, labetalol is a shotgun.
How do we classify this one?
It's a combined alpha and beta adrenergic receptor blocker. It's available both orally and intravenously, which makes it incredibly versatile.
Combined alpha and beta. That sounds like it does everything.
Yeah.
How did that mechanism work?
It acts as a double agent. It blocks two types of receptors simultaneously. First, it blocks alpha-1 receptors peripherally.
And alpha-1 blockage causes vasodilation.
Right. Correct. It relaxes the smooth muscle in the blood vessels, lowering systemic vascular resistance, or SVR. Now, usually when you dilate vessels with a pure vasodilator like hydralazine, what happens to the heart?
Reflex tachycardia. The pressure drops, so the baroreceptors scream at the heart to pump faster to compensate.
Exactly, the heart races. But labetalol creates a trap for the heart. It also blocks beta-1 receptors on the heart itself, so it prevents that reflex tachycardia.
That is clever. So you drop the pressure by opening the pipes, but you also put a governor on the engine so it doesn't race.
Precisely. The net result is a lower blood pressure without increasing the heart rate. In fact, the heart rate might drop slightly. It lowers myocardial oxygen demand, which is great for the heart.
Is it a 50-50 split? Is it blocking alpha and beta equally?
No, and examiners might ask this to test your precision. It's usually much more potent as a beta blocker than an alpha blocker. The ratio is roughly 1 to 7, so alpha to beta when given IV, and about 1 to 3 when given orally.
So it's predominantly a beta blocker with a side of alpha blockade.
Yes, but that side of alpha blockade is enough to lower the SVR significantly.
Let's talk pharmacokinetics. Methyldopa was slow hours to work. What about labetalol?
Labetalol, the fief, is fast. Onset is within 5 minutes, usually 2 to 5 minutes. This makes it ideal for hypertensive emergencies.
Right.
Oral is slower, used for maintenance, but the IV form is the hero in the emergency room.
And metabolism.
Extensive hepatic metabolism. It has a high first-pass metabolism, which limits its oral bioavailability, but IV gets around that. The elimination half-life is about 5 to 8 hours, so it sticks around long enough to be useful, but clears fast enough if you run into trouble.
What about the hemodynamic profile? We mentioned SVR drops.
SVR drops. Cardiac output is generally maintained or slightly reduced because of the beta blockade preventing the heart from overworking. But importantly for our obstetric theme, uterine blood flow is preserved.
That is critical.
Yeah.
Why is it better than just using a massive beta blocker or a pure alpha agonist?
Well, if you use a pure beta blocker, the alpha receptors are unopposed. In the body's stress state, circulating catecholamines might hit those alpha receptors and clamp down on uterine flow.
Okay.
If you use a pure alpha blocker, the hypotension might be too severe. Labetalol finds that sweet spot. It avoids the drastic reduction in placental perfusion.
So, clinical uses. This is an exam favorite.
Number 1, hypertensive disorders of pregnancy. It is first line for acute severe hypertension like severe preeclampsia or impending eclampsia.
What is the target there? If a woman comes in with a BP of 180 over 110?
You want to bring that down to a safe range, usually around 140 to 150 systolic and 90 to 100 diastolic. You don't want to crash it to normal immediately because you'll hypoperfuse the brain, but you need to get it out of the stroke zone.
And you can titrate it easily.
Labetalol is perfect for this titration. You give 20 milligrams, wait 10 minutes, give 40 milligram, wait 10 minutes. You can step it up.
What?
Hypertensive emergencies in the general population ICU, ER settings, perioperative hypertension. It's great for controlling BP during surgery without causing tachycardia. And it can be used in pheochromocytoma.
Pheochromocytoma, I thought beta blockers were dangerous there because of unopposed alpha action.
You're sharp. That is a classic rule. Never give a pure beta blocker first in pheochromocytoma because the alpha receptors will go wild and cause a hypertensive crisis.
Right.
But because labetalol has alpha blocking properties, it can be used generally after some alpha blockade is already established just to be safe. It is safer than propranolol, but you still need to be careful. The alpha blockade in labetalol might not be strong enough to overcome a massive catecholamine surge from a tumor, so caution is key.
Side effects and precautions. What can go wrong with labetalol?
Well, it's a beta blocker, so you get the mechanism-based side effects. Bradycardia. If the patient already has a slow heart, be careful. Heart block. And the big one, bronchospasm.
Because of the beta-2 blockade.
Yes. It's non-selective on the betas. So if you have an asthmatic patient, labetalol can trigger an asthma attack. This is a major contraindication to watch out for in the patient history.
So if the examiner says patient has a history of asthma,
you must pivot to hydralazine or nifedipine. Do not say labetalol. It's a trap.
and specifically for the baby.
Neonatal hypoglycemia or bradycardia is possible, though rare, but generally it is considered safe.
Anesthetic implications for labetalol.
If your patient is on labetalol and you're giving general anesthesia, remember that volatiles like halothane or isoflurane are myocardial depressants. Labetalol is also a myocardial depressant via beta blockade. They can be synergistic.
So you could see more hypotension.
You might see more hypotension or bradycardia than you expect. Yeah.
That's good for intubation.
Excellent. Laryngoscopy causes a massive sympathetic surge tachycardia and hypertension. Labetalol blunts that beautifully because it caps the heart rate. It's often given just before induction in preeclamptic patients to blunt that response.
Okay, we've covered the 2 pillars. Now part C. This is where we bring it all together for the exam, the comparison.
If the examiner asks you to compare them, visualize a table in your head.
But let's build that mental table. Column A is Methyldopa, column B is labetalol.
Mechanism. Methyldopa is a central alpha-2 agonist.
Okay, and labetalol.
Labetalol is a peripheral alpha plus beta antagonist.
Right, onset. Methyldopa is slow. Hours. It's a prodrug.
And labetalol, the Y, is rapid.
Minutes. Use case. Methyldopa is for chronic maintenance.
Labetalol is for acute crisis and maintenance. It does both.
Side effects. Methyldopa has sedation and that autoimmune hemolysis.
And labetalol has bronchospasm and bradycardia.
That is a high-yield summary right there. Let's talk about the obstetric anesthesia protocol specifically.
In the obstetric world, the protocol is usually, number 1, chronic hypertension found in the clinic. You start Methyldopa. It's gentle and safe.
Okay.
Number 2, acute preeclampsia in the ER with a BP over 160/110. Labetalol is the workhorse. Hydralazine is the backup.
And number 3.
Perioperative for a C-section. Labetalol is great to blunt the response to the breathing tube. Methyldopa patients will just need less gas, as we said.
Now the traps. The things that make you fail. What are the Viva traps?
Okay, trap 1. Doctor, can I use Methyldopa for an eclampsia emergency?
And the answer is?
Answer, and no. You must cite the slow onset. 4 to 6 hours is too late.
Trap 2. What is the mechanism of Methyldopa?
Answer, do not just say false transmitter. You must explain the prodrug conversion to Alpha-Methyl-Norepinephrine and central alpha-2 stimulation. That shows you know the current pharmacology.
And trap 3 has to be the Coombs test.
Of course. Answer. You have to know the distinction between a positive test, which is common and often harmless, and actual hemolytic anemia, which is rare but harmful. If you say Methyldopa causes anemia in 20% of people, you will be corrected and you will lose marks.
And trap 4. confusing clonidine with Methyldopa.
Yes. Both are central alpha-2 agonists, but clonidine is direct-acting. Methyldopa is a prodrug that needs conversion. That distinction matters. Also, avoid confusing the alpha blockade of labetalol with something like pritzosin. Labetalol is alpha-A and D-beta.
For the written paper, the 20-mark theory question, how do we present this?
Structure is everything. Start with the biosynthesis pathway diagram. Draw tyrosine to dopa to dopamine to NE. Show methyldopa entering this pathway. A diagram is worth 5 marks instantly.
Visuals are key.
Then do a receptor blockade schematic for labetalol. Draw a blood vessel with an alpha-1 receptor and a heart with a beta-1 receptor. Show labetalol blocking both.
And a table.
Finally, use that comparison table we just talked about. Examiners love tables. It shows you can synthesize the information quickly and clearly.
And wrap it all up with a strong summary.
Your conclusion should always relate back to the physiology of the mother and the fetus. Something like, in summary, while methyldopa offers a proven safety profile for chronic management via central modulation, labetalol provides critical acute control via peripheral blockade, preserving uteroplacental perfusion. The choice depends on the acuity of the hypertension. That sounds like a consultant speaking.
That is perfect.
One final thought for the road. Always remember that treating hypertension in pregnancy is not just about fixing a number on a monitor. It is about preventing a stroke in the mother while maintaining blood flow to a baby that is dealing with a compromised placenta. Every milligram you give has to balance those two competing needs. That is why we learn the pharmacology so deeply.
So get those pathways drawn out. Practice drawing the enzymes. Practice the table.
Confidence in the Viva comes from understanding the mechanism, not just memorizing the dose. If you know why it works, you can answer anything they throw at you.
You have got this. Good luck with the exam.
Good luck. Go crush it.